The last talk is on management of neons, non-arteritic AIONs. The basic picture is what we know so far is an ischemic injury, but still we don't know which triggers those part is still under investigation. So one of the most common acute optic neuropathy in over age, middle age and elderly population, and it is multifactorial. It's ischemia, small optic disc, and systemic risk factors. But still, we don't have universally accepted treatment yet. Not moving. My slide is Brazilian. Okay. So these are the controversies and challenges in management of neons. Is a lot of empirical treatments are available and unclear pathophysiology and lack of robust clinical trials. So basically these are the therapeutic options are available. One is observation and medical treatment and surgical interventions and experimental treatments. All are focused to preserve the or improve the vision and reduce the disc edema and improve the disc perfusion. So these are the management strategies available at the moment. So basically you manage the modifiable risk factors like hypertension. You on one side you manage the hypertension, in the meantime not to go into a nocturnal hypotension where it one of the suspected factor. These neon patients, they most of the time they gets up in the morning, by awakening they realize that they lost the vision. So most people are suspecting it is due to nocturnal hypertension, and diabetes and hyperlipidemia. Optimizing is very important, and obstructive sleep apnea also most of the times has been investigated, it can cause. And sleep positioning, that is important because these small disc patients, they have, when they sleep on one side, the IOP rise will compromise optic nerve perfusion. So you can ask the patient when to not to sleep on the side where he got vision loss. And the medication, lot of anecdotal evidences are coming on. Some of the drugs like phosphodiesterase and semaglutide. Semaglutide is one of the drug. It's getting popular. One is managing the diabetes and the weight loss. People are using for their self-medication semaglutide for weight loss. And the other opposite side is an active management of medical treatment of systemic steroids that has been tried early part of this this disease. It has shown some improvement, but it has a lot of side effects. And intravitreal anti-VEGF, all the molecules, bevacizumab, ranibizumab, and aflibercept, all are tried. There are small studies available. They give positive results, but they are small retrospective trials. And optic disc, optic nerve head sheath decompression, there's a prospective trial done for 2 years. Finally, they found no advantage, and possibly it is very harmful to the eye. And now the most latest one is, I'm happy as a VR surgeon, the prophylactic vitrectomy might help for this small disc patient, preventing from developing neon. So what will happen if you don't treat the patient? In generally, they have not a good prognosis, and majority of the cases results in vision loss with a 40 to 50% having significant visual impairment or being legally blind. And after some time of stabilization, the small group of patients, they getting recurrence in the same eye. What about the other eye? The fellow eye, it has been reported to occur, can have a same condition, same problem within 5 years. So the medical treatment like systemic steroids, yes, it can improve, but you have to treat for its side effects like cataract and glaucoma. And intravitreal steroids also same, though it is locally given, but the main problem is it can cause glaucoma and increase IOP, and it can cause negative impact on disc perfusion. Anti-VEGF injections like bevacizumab, there are small studies showed, some showed there are benefits, some no. And aflibercept is recently came a study from Taiwan. They have shown a small number of patients. It has been shown that there is improvement in the visual acuity. Ranibizumab, same, it has some benefit, but those are small retrospective clinical data. But we need, there is a need for larger, well-powered, randomized controlled trials. So what I am working in a state hospital, so I don't have a lucrative anti-VEGF molecules in my hospital. So we start treat these patients with biosimilars of bevacizumab. So there were 11 patients were treated during November 23 to July 24. There are 3 patients lost the follow-up. And baseline demographics like age and gender and other, including the best corrected visual acuity, which is measured more accurately with using logMAR scale. And eyes with dyschedema and vision loss less than 1 month were included for the intervention. 1.25 milligram of per 0.05 ml of bevacizumab. It's a biosimilar we use. And best corrected visual acuity and the adverse effects were assessed monthly for 6 months. And when there is no improvement from this baseline, we have repeated 1 dose, maximum of 2 doses during the follow-up. So this is the results. So the mean age group was 57.4 and mean duration of vision loss was 2 weeks plus or minus 5.2 days. Best corrected visual acuity, the baseline best corrected visual acuity was 1.2, that means less than 660, and the mean improvement was noticed at 0.6 logMAR scale. This is a summary of that findings. You can see around 7 lines improvement we have seen among those treated patients. But the main drawback of my study was there is no control arm, and we took it from a reference control from a study published by Taiwanese ophthalmologists. We have used 10 control untreated eyes. If you look at the graph, you can see the control. There is very less improvement compared to our study. So there is a usefulness I could see in my small retrospective study, and my real world data shows some promise. And we need large scale trials to confirm this thing. Thank you.
Excellent presentation, and it's novel, but there are few articles that they say they have done studies like that, but it is not promising any difference whether you give the vaccine or not. So what made you think in this line? What is the stimulant that you motivated to give the injection?
Yeah, this plan sparked from me by Taiwanese publication. They have used aflibercept to treat acute nions, and they have shown this improvement. So I thought only thing I can offer to them, modify the systemic factors. Other than that, I can't offer anything usually when nions comes. So, and natural history also not very promising. So I thought rather than leaving them to modify, because modifier is very important for their cerebrovascular event, to prevent this wake-up call for them, the cardiovascular event. But for the eye, what can I do? But I think treating them actively if they entered you into your place in an acute phase, there is a possibility you can benefit by treating actively.
I think they did a similar study in Melbourne, and now they are not giving this. They are not conducting this trial anymore. So currently, we just treat them empirically, and we are not giving any injections, intravitreal injection.
Basically, the hypothesis is it can reduce the compartment syndrome-induced axonal loss. But still, there are small studies. Some they are promoting. Some says it's no benefit at all.
There is no harm in giving injection. They used to give steroids, but even I think what the neurologist which you told, he was advocating oral steroids for this.
Yeah, it was the
decreases-
Herard and
yeah,
Herard.
that's right.
They have started oral steroid at
Oral
the first
steroid.
treatment when they
That's
have
right.
described,
Yeah,
and they found benefit.
yeah.
But still, they get the problem of
Other
steroid-induced
steroid, yeah.
side effects,
Yeah,
which may
yeah.
be more
They're
than.
not long term. It's because it's a compartmental syndrome, only a short course of steroid is given. Not like the arteritic optic neuropathy where they have to give it for a year or year and a half. This is only a short course of steroid is given.
That's actually to prevent the acute
Swelling,
further
acute
of-
swelling.
Acute swelling and
yeah, that's right. yeah.
compartmental syndrome,
That's
relieve the
right, yeah,
compartmental syndrome. So
That's right.
basically, that is a hypothesis on. But the latest one I have seen, the ophthalmology journal, now they suspect it because of the anomalous vitreopapillary traction causes the vessels to kink and causing the ischemic injury. So they promote to go, might be a prophylactic vitrectomy to induce a PVD around the disc, which may relieve the compartment syndrome.
Because they used to, even sometime when we do cataract surgery, you can get an non-arteritic anterior ischemic optic nerve. They felt that it is the movement of the vitreous phase from the optic nerve which caused that non-arteritic. So that's what one of the theory. But then they used to even do, I don't know whether you may, they used to do slit on the optic nerve, like relieving the pressure in the optic nerve, but that trial was no, it didn't proceed through because they didn't have any benefit, or in fact it worsened the situation in some places. Optic nerve sheath fenestration like thing. Yeah.
What about peribulbar steroids? Right?
Yeah, people try the peribulbar local steroid injections. It's 80% of the people benefited. But still it has a problem of, because of the injections, the main issue is glaucoma. If you increase IOP, it might cause further damage to the nerve. So even an intravitreal injection, we usually do a paracentesis and make sure the IOP won't go up, because that will cause more damage.
Yes. Very true.
Thank you very much for your kind and thoughts you have shared with us. It's more interesting we shared both sides rather than have a one-way lecture. Thank you very much on behalf of College of Ophthalmology, Sri Lanka.